Okay. Hello, everyone. Can everyone hear me? Hello. Okay.
Yes, we
Okay.
can hear you, girls. Yes. Hello.
Yeah, okay. Okay, guys. So we left today at the mood disorders, and today we are starting from uh, peripartum mood disturbances, right? Okay. So today I will try to teach in a new way because I think this way is more effective for psychiatry and as well as for your family. So we'll do a question-based style of teaching. So these were my own questions. I made them for you guys, so I could explain those things in a better way, the psychiatric things. So the first case is a 28-year-old woman who is gravida 1 and para 1 presents to the OBGYN 5 days after the postpartum, 5 days after postpartum. So she is crying. So the first thing that you guys need to note is that she is crying, right? Okay. So that is sadness. So that is one criteria of MDD. She's feeling overwhelmed. The second one. The third one is she's having sleep difficulties, right? She's irritable, right? So these are the four ones. Okay. So now I I have marked right now four symptoms that are present in this woman out of five. So there are four Siggy caps out of five, right? So this is the question USMLEs want you to test and know about. So what is the most likely diagnosis in this case? So they confuse three things here. So the first one is postpartum hues or the postpartum blues. The second one is uh, postpartum MDD, right? And the third one is postpartum psychosis. So in this case, since only four out of nine criteria have been met, so only four out of nine is met. So it means it is not MDD. And since there is no psychotic element, there are no delusions, there are no hallucinations, there are no negative behaviors, there is no bizarre speech, there is no disorganized speech, there is no cognitive problems, so no psychosis is present. So, right, so this would be a diagnosis of postpartum blues. Okay. So this is a characteristic case of postpartum blues. Another thing, it will start 2 to 3 days after pregnancy. And this is very common after pregnancy. This is the most common psychiatric problem after pregnancy. So what's the treatment for this? So for the first one is initiate sertraline. So we cannot initiate sertraline because that is a treatment for postpartum MDD. And this patient is not fulfilling the criteria for postpartum MDD. This is not the answer. Hospitalization. We do hospitalization when there is postpartum psychosis. This patient does not have postpartum psychosis because there are no psychotic elements, there are no delusions, there are no hallucinations, there are no thoughts of harming the baby, right?
Mhm.
Then, No, it's not present, right? So they can ask you another question. What are the risk factors for postpartum psychosis? So if it is a first pregnancy, the patient has a history of psychotic disorder, bipolar disorder, any medication change, or the patient has a family history of postpartum psychosis, then this thing would be present. And in that case, we do hospitalization and we initiate an atypical antipsychotic, right? And if that is not enough, we then move on to the initiation of electroconvulsive therapy, right? For begin cognitive behavioral therapy, this is another thing that we will do in postpartum MBD, right? But in this case, we would provide reassurance and schedule a follow-up in 2 weeks because this is a case of postpartum blues. And in postpartum blues, we just provide reassurance and do a follow-up in 2 weeks. Now let's move on to the other question. So a 32-year-old woman comes with a history of bipolar 1. So first thing is she has
Bipolar.
a
One.
bipolar. So
So
a
it
risk
is
factor
a
is
history.
already present.
And then, um,
Okay, so a risk factor is already present. So whenever you see a risk factor for a certain disease, just think of that disease in the first place, right? So whenever a patient comes to you, that patient comes to you with his own story, with his or her own story, and always look at the whole story instead of just looking at the symptom. So if I'm looking at this person's story, I can see that this person has a history of bipolar disorder. She is presenting after pregnancy, and she is saying that her voices are coming, that her baby is processed. So this means these voices are known as hallucinations. So these are auditory hallucinations that are present. So this means it is a case of psychosis, which is known as postpartum psychosis. So what is the next best step? So prescribe lorazepam and discharge NOC. We won't do that. Start fluoxetine and observe. We do that in MDD, postpartum MDD. We can do ECT as the first line therapy. No, the first line therapy would be initiating hospitalization and antipsychotic therapy. And if the person does not recover after this, then we can move on to do ECT as the first line therapy, right? So ECT and the first line therapy won't be the right answer. It would be the second best option in this case. Okay. So the third question is a 70-year-old man with woman with recurrent major depressive disorder present with suppressive symptoms and psychosis. She has failed a trial of multiple antidepressants and antipsychotics. She has stopped eating and is severely withdrawn. Her daughter reports concern. What would you do now? Right? So I have told you yesterday. So now we are moving on to another topic, which is electroconvulsive therapy. So what is electroconvulsive therapy? It is a rapid acting method which will easily treat refractory depression. So what are the indications of electroconvulsive therapy? This is very important and keep all of these in mind. So whenever a patient is having refractory depression, or the patient is having catatonia, or the patient is acutely suicidal, or the patient refuses to eat anything, then we do this electroconvulsive therapy. What is the mechanism of action? What is the physiology by which this works? This will initiate a tonic clonic seizure in the body, and there will be neuromuscular blockade and anesthesia effects. And what is the most important side effect of this? So they love to ask, what's the most important side effect of electroconvulsive therapy? So the most common side effect of electroconvulsive therapy is amnesia. So there would be, and this amnesia is partial and it will recover. So a partial amnesia which will recover is a sign and symptom of, we could say, electroconvulsive therapy, right? And it will resolve in 6 months. There are no contraindications to this, and this is even safe in pregnancy and older adults. So, right? So, since this patient is having, so look in the question, this patient is having multiple failed trials of antidepressants and antipsychotics. That means that this person has what do you call as refractory depression. So, such depression which cannot be treated with different things is known as a refractory depression. So, in case of refractory depression, we would give the patient uh, uh, a case of right? And here that patient is not on. So does anyone
Doc, your mic is breaking.
okay, wait. Is it okay now?
Yes, yes, it is.
Oh, now let's move on to the next question. Right. So now we are doing the suicide. Right. So 24-year-old male comes to the ED by the police. posting a video all about feeling hopeless and wanting to end his life. He has a history of depression, recent breakup, and he lives alone and has a gun at home. So, what is the most stronger predictor of suicide in this patient? So, remember, at Capri, they love to ask what the risk factors of suicide. So, what is the number one risk factor of suicide? So, always remember that, first of all, one important thing about suicide is that women try more often to do suicide. But the way in which women do suicide, the attempt of suicide, it's mostly non-lethal. But the way in which males do suicide, it's mostly lethal. So where males die more from suicide, whereas females attempt more for suicide. The most important risk factor for suicide is a prior history of suicide, right? This is very, very, very important, right? So, a prior history of suicide is the most important prognostic and indicator for suicide, right? Okay, so that's the number one. What's the second most common cause? And what's the second most common? And that one would be an access to firearm. Right? So if there is an access to firearm, that would be the second most common cause of suicide. So that could be an access to firearm, that could be an access to any drug which causes suicide. So any such thing means that there could be that could be suicide, right? So now we're moving on to panic
Doctor,
disorder.
can I
So
ask you a
what is
question?
panic disorder? Yes.
Sorry.
Wait a
So
second.
like,
Yes, yes.
so I wanted to ask, like,
Yep.
so in the question they didn't mention like a previous suicide attempt. So if they give us a question that doesn't mention that there was a previous suicide attempt, but in the options there were, would we still mark previous suicide attempt, or would we go for the
No,
thing that's the
no,
most?
no, no. So, okay, so I think I forgot to write in question that he has a previous
Okay.
suicide history, right?
All right. So they would
Okay.
mention. Okay. Thank you.
Yep. So this is a very other important point that you need to know is that this happens a lot in US families actually. So remember this thing. Even if there is a very strong risk factor that causes a problem in a lot of people. So for example, if a person, so this question, so let me tell you another pulmonology question for you. So if they ask you, a person has smoked, so a person smokes for the last 40 years, and now that person is having so a person smoked for the last 40 years, and they ask you what's the strongest risk factor in this patient for developing lung cancer. So obviously that would be smoking, right? But if a
Yes.
female with adenocarcinoma of lung adenocarcinoma of lung, a female comes to you with adenocarcinoma of lung, and they ask you what's the most strongest risk factor in this case, and she does not smoke. So remember, adenocarcinoma is occurring more commonly in that case. The most would be
Sorry,
female
Doc.
sex and not
Your
smoking
mic
because
is
that
breaking. We didn't hear you. You got cut off. You're breaking.
thing. If a male with a smoking history of what is expected in this patient for that case would be smoking, right? But if a female with a diagnosed problem of a then in that case, the most that women have hasn't ever smoked, right? So in that case, the most strongest risk factor in that case would be a female age, because females are very more likely to get adenocarcinoma of the lungs, especially those females which are not smoking. And in that case, that female was not smoking. So the most important risk factor became female sex, right? So always see in the question, and this is very excellent on your part, and this is very impressive that you paid such close detail and keenness on the question that the suicide history was not mentioned. So if the suicide history is not mentioned, you cannot mark suicide history as the previous as the most important risk factor. Then in that case, access to side firearm would be the most important. But if
Thank you,
suicide
doctor.
history is present, then suicide history becomes the most important one, right? And remember, they will always give you such options like history of breakup, or history of worthlessness, or his father is very abusive. So remember, these are risk factors for suicide, but these are not as important of a risk factor as access to firearm or previous suicide attempt, right? Okay. So the
Thank
next
you.
one is okay. So the next one is a 26-year-old woman comes to you with several episode of chest pain, palpitations, dizziness, and a fear that she was drunk. So remember, there's this important keyword that a fear that she was drunk, right? So, number one. So, I am doing this in question style to tell you how are the things in how that certain niches in the question or certain words that carry so much important and make or break the question, right? So, a fear that she was dying. So, that is the number one. So, remember, whenever you see chest pain, whenever you see palpitations, whenever you see dizziness, you can be thinking of myocardial infarction, you can think of pericarditis, you can think of pheochromocytoma, you can think of aortic dissection. I could list 100 diseases that can do all of these things, but there would be a very differentiating factor between all of these, right? But in this case, there is an important keyword that mentions that this patient has a fear that she was dying. And the second thing, her symptoms begin suddenly while shopping and peaked within 10 minutes, right? So it's a very fast peak. The third important thing is she had similar episodes 3 times in the past month, and she's always fearing another attack. Right? So remember, in panic disorders, the symptoms are just like of an asthma attack or hyperventilation, or the patient is getting palpitations, dizziness, paresthesia, depersonalization, realization, abdominal distress, fear, fear of dying, and something like that. The main factors are, let me highlight all of those things. So the first one is intense fear. An intense fear will always be present, right? Secondly, the peak would be in 10 minutes. Be in 10 minutes. And the third thing would be that the patient would have a history of previous such attacks and she would always fear another attack. So this is very important about panic disorder, right? And all of these are the signs and symptoms of fear. Okay. So what would be the most likely diagnosis? So the most
Doc,
likely diagnosis would be, yep, yes.
your mic, is it possible to change, like, to, because you keep getting cut off and it's cracking and you come back, so we used to lose the train of.
Okay, okay. I'm sorry about the mic. If it breaks in the middle, you can tell me, and I would repeat that sentence. Right? So I can repeat. So I was saying that in panic disorder, there would be 3 to 4 most important key factors, along with chest pain. The first one would be that there would be a fear of dying. The second one would be the peak would be within 10 minutes. The third one would be the patient would have such similar attacks. The fourth one, the patient would be fearing another attack. The patient would be worried about another attack. So remember, these 4 things are always present in a panic disorder. In acute coronary syndrome, ECG won't be normal, right? Labs won't be normal. Generalized anxiety disorder does not occur in an acute way. Similarly, somatic symptom disorder does not occur in a. So panic disorder is the right thing. So now, what is the treatment? So, as far as treatment is concerned, remember, if a patient of panic disorder comes to you in an emergency, so if it's an emergency situation, then the right answer would be benzodiazepines. So then we would give a benzo to the patient, right? But if but if that patient comes to you without panic disorder occurring right now and the patient has a history of panic disorder, then we give the patient CBT and SSRIs. Okay. So then CBT and SSRIs are the right answers. But in case of emergency, always give benzos. So always seeing the question that if they are asking about the chronic thing or the acute thing. So for example, let me give you another example from a question about neurology. So all of you have heard about multiple sclerosis, right?
Yes.
Yes,
Okay,
doc.
so multiple sclerosis, they can similarly give this same thing in a different way. So they can say you that patient is having acutely an attack of multiple sclerosis. So in acute attack, you would give steroids to the patient or methylprednisolone. But if the attack is chronic or you want The patient has a history of multiple sclerosis, but right now the patient is normal. There is no such symptoms. Then we would give the patient beta interferon, right? Or glatiramab or natalizumab or any such drug, right? So look at what the question is asking you to. Okay. So now two other things. So these are two questions that are very much related. One is social anxiety disorder. The other one is general. One is social anxiety disorder, and the other one is agoraphobia. Right. So what is social anxiety? What is phobias? So phobia is any anxiety or any fear that is present and the patient knows that the fear is very excessive. So, for example, if someone has a fear of heights, if someone has a fear of trucks, if someone has a fear of clowns, if someone has a fear of blood, if someone has a fear of needles, all of these are phobias, right? So, there are some subtypes of phobias. So, it could be social anxiety disorder. So, social anxiety disorders mean you have a fear of getting embarrassed in social situations. So, for example, if you cannot do public speaking, you cannot speak on the mic, you cannot use public restrooms. So, that would be social anxiety disorder. In case of social anxiety disorders, again, we give CBTs and SSRIs for the chronic management. But in case of having a social anxiety disorder and it is an acute event, then in that case, what we would do is that we would give the patient beta blockers for the acute thing. So, for example, I had one of my friends, and during residency, so he had social anxiety disorder. So during residency interviews, he would always stammer, and he was very fearful, and he could not give the interviews in a proper way, right? So what did we? So in that case, he was having an interview after 2 days. So in that case, we could not give our friend a CBT or SSRI. Why? Because in that case, only 2 days had CBTs and SSRI won't affect that patient in 2 days. So we had to give that patient we had to give the, okay. Okay. So in that case, we had to give our friend a beta blocker, right? So in acute cases, we give beta blocker, whereas in chronic cases, we have to give MCBTs and SSRIs. Now again, there is another condition which is known as agoraphobia. So what is agoraphobia? Agoraphobia means that you have a concern that any kind of help won't be available. So you feel very trapped in certain situations. So for example, some people have agoraphobia of exams. So they cannot sit in the exam room because when they sit in the exam room, they think nobody is going to help me here and I'm gonna die here alone. Right? So that another some people have agoraphobia of being in a train or being in a crowded bus because they think they would die of suffocation and no one would be here and no one would be able to help them. Some people have agoraphobia of getting outside of home. They think if they get outside of home, no one would help them and they would die. Right? So this is agoraphobia. So let's solve these cool questions first. So a 30-year-old man avoids traveling by plane due to fear of crashing. So see, so the first line tells us that this patient is having a phobia. He knows it's irrational. So the other thing that I told you that the patients of phobia know that this thing is irrational, right? This is the main telltale thing of phobias. It's small thing, but is a very noticeable thing that the patient will know that it's irrational, but it still refuses to fly even when required for work. His anxiety starts a day before scheduled flight and becomes overwhelming during the boarding. Right? So, what is the most appropriate treatment? Okay. So the most appropriate treatment won't be a short-term benzo. So it would be a cognitive, not be SSRIs, not be hypnosis. So it's a cognitive behavioral therapy with exposure. So it is known as exposural behavioral therapy. So what is exposural behavioral therapy? In exposural behavioral therapy, we increase the exposure a bit, and by a bit. So first, we would show the patients some photos of a plane. We would show the patient some photos of flying, and then we would show a patient a video. We would ask him to play a game in which there is flying, and then we would take the patient to some kind of heights, and and by step, gradually would increase that patient's exposure. So this is phobia, and this is how we treat it. So a 19-year-old college student reports skipping classes to avoid being asked questions in front of peers. Right. So again, this is a fear of public. Why? This is a fear because he thinks he would get embarrassed. So remember, in case of social anxiety disorder, there is a fear of speaking in the public because the person would get embarrassed. So that is why the patient or the person do not ask the questions, right? And he gets palpitations and nausea during pregnancy. Her symptoms begin in high school and have worsened in college, right? So what is the most likely treatment? So since this is a performance subtype, so this is performance subtype. Why? Because this only occurs when he has to speak in front of right? Here. So whenever it's since it's only occurring in the presentations, so we would just do beta blockers as needed, right? Does anyone has any question? Okay, so the next one. 35-year-old woman refuses to leave her house alone, right? So again, those same things, the patient refuses to leave the house alone. The patient avoids public transport, shopping center, and open field. She says that she feels trapped, right? So in psychiatric disorders, you have to understand what the patient is thinking logically and by the mind. So the patient is thinking that she will feel trapped and no one will help her if she has a panic attack. So don't think that if the question mentions a panic attack, then it is a diagnosis of panic attack. Since in this case, the main concern of the patient is that she is having a feeling of being trapped. So, and she thinks no one would be able to come for her help. So then it will be a case of agoraphobia. Why is it a case of social anxiety disorder? Because in order to make a diagnosis of social anxiety disorder, we have to think that the patient is embarrassed of that situation. But the question on the woman never mentions anything about being uh, embarrassed, right? So it's not social anxiety disorder. Why isn't it a specific phobia? You could say it's a specific phobia because it's not, if it only occurred at a public transport, if it only occurred as a shopping center and an open field, then maybe it would be a specific phobia. But it's occurring in a lot of different places, and the main root cause that is coming is that she's feeling trapped in all of those places. So that is why it's not a specific phobia. Why is it a panic disorder? So for panic disorders, four things. Remember, look at four things. The number one is fear. Okay, so this patient has fear. Does this patient has any signs of fear? No, no signs of fear are present. There is no chest pain, there is no palpitation, there is no dizziness. Okay, now let's move on to the third one. Does the patient has such attacks? No, so the patient has no attacks. Does the patient worry about those attacks? Since there are no attacks, the patient cannot worry about those attacks, right? Okay, so the next one. A 22-year-old woman, 22-year-old college student washes his hands for 2 hours daily. He says he knows it's excessive but cannot stop, right? So this is an obsession. If he resists, he becomes overwhelmed by anxiety and images of contamination. So this is a characteristic case of obsessive compulsive disorder. In case of obsessive compulsive disorder, first of all, there would be some obsessions. So let me tell you what are obsessions. So obsessions mean that there are recurring thoughts or sensations that you need to do something, right? And they cause distress. So, right, in this case, these are the obsessions that he needs to wash his hands. And these are the obsessions. These are the obsessions. And this is the, wait a second. Okay. That are the obsessions, and then you do such things to complete them. So that or you do repetitive things. So the obsession is the patient is having images of contaminations, and in order to make those obsessions go away, there are some compulsions. So the compulsions are that the patient washes his hands 2 hours daily, right? So this is the compulsion. So So the first thing that is important is what is the association? This is known as obsessive compulsive disorder. So what are the associations of obsessive compulsive disorder? What is the thing obsessive compulsive disorder is associated in? So we have studied yesterday, and remember it. Obsessive compulsive disorder is associated with ADHD, Tourette syndrome, right? So it is associated with Tourette syndrome. So the patients of Tourette have obsessive compulsive disorders. Second important thing is the patient does not know that what his problem is leading him into. He does not know what will this thing cause. He just does it. So he for know what will happen. He will eventually get scars on his hand. He will get burns on his hands. His hand will bleed. There would be a lot of wounds on his hands. Even ulcers can occur on his hand due to so much chemical and due to so much washing and so much friction. But he's not aware of any of those things, right? So this is obsessive compulsive disorder. I have seen a real life patient of obsessive compulsive disorder, and he had lost 25 to 30 kgs of his own weight eat without washing his hands. So whenever he came to eat, he first washed his hands and then came back, and then he had to wash his hands again. So he could not eat anything because whenever he started to eat, he thought that he had to wash his hands, and that in that thing the whole day passed by. He stopped his studies, he stopped eating, he became very weak. He had to be hospitalized just because of this obsession that he had to wash his hands because the food was contaminated. So he had to do that compulsion, right? So the patients of OCD does not know this. So there is another condition which is known as obsessive compulsive personality disorder. This is OCPD, right? So in obsessive compulsive disorder, the things that you do will lead you to very worse outcomes. But in case of obsessive compulsive personality disorders, the thing you do will lead you to better outcomes, but it's the same thing. For example, I say that so, for example, a student says that he needs to revise his books 5 times before going to the exam. But in reality, studying only 1 time is enough. So he has an obsession of completing the book 5 times, but he completes it 5 times. So he's so obviously he would retain a much more amount of knowledge. His knowledge about medicine would be much more greater, and that thing would lead to his own benefits, right? So he has a characteristic personality trait. So remember, in obsessive compulsive personality disorder, you do not have an obsession about one thing. You have an obsession about everything of your life. So everything of your life. So you have an obsession about every aspect of your lifestyle. So have an obsession that you need to keep your car clean. That person with an obsession to get the fuel checked, so get the engine oil change of his car every 10,000 kilometers. He would try to get it done as soon as possible, right? He would get his, so for example, if he has a pet, he would try to do so if he has a pet, he would try to do everything to get the best possible healthcare checkup of his pet, right? So obviously that would lead to better health outcomes, but that would cause a lot of problems and a lot of stress in that person's lives. So that is obsessive compulsive personality disorder because that person is treating a lot of obsessions, a lot of compulsions a same day. Because in obsessive compulsive personality disorder, the main problem is the person wants to keep everything in order and in a straight line, right? But in obsessive compulsive disorder, the problem is related to one thing only, and that thing is causing very bad outcomes in the patient life. So, what is the treatment of obsessive compulsive personality, obsessive compulsive disorder? So, we do CBT and SSRIs, right? So, CBT, and SSRIs are the main treatment for obsessive compulsive disorder. So now there are two more important. So trichotillomania. So trichotillomania is also a form of obsessive compulsive disorder. In you specifically have an obsession of pulling out your hair. So as a compulsion, you pull them out. So causes very much distress, and it will lead to worse outcomes as you will get bald and there will be areas of thinning, right? So there are two things. So first one is alopecia, and the second one is trichotillomania. So in both of these conditions, a patient will go bald. But what would be the difference? In trichotillomania, when you look at the scalp of the patient, first of all, if a patient of trichotillomania comes to you, in the history, that patient would be having some kind of a psychiatric problem being already present in the patient, right? So, so if I write trichotillomania, and the second one is alopecia. So alopecia means normal baldness, right? So in alopecia, there would be no psychiatric history. In case of trichotillomania, psychiatric history is present. In case of trichotillomania, the hair shafts would be of different length, and they would give you this in question. Different length hair shafts. But in case of alopecia, hair shafts would be of same length. Okay. So what's the treatment for this condition? The treatment for this condition is CBT. You cannot give SSRIs in this condition. And remember me as where the NBMEs and USMLEs would try to trick the hell out of you by giving you SSRIs in this question as well. And since the treatment for most of the psychiatric problems is SSRIs, you would be very much compelled to go with SSRIs. But remember, in case of trichotillomania, you cannot give SSRIs. Similarly, in the case of body dysmorphic disorder, you cannot give SSRIs. The main treatment is CBT. So what is body dysmorphic disorder? So body dysmorphic disorders mean that there is a very minor problem that is going on in a person, and that is causing a significant emotional distress, and the patient is thinking that this problem is a very big problem, and that as a result, the patient do a lot of grooming. So for example, oh, okay. So let's do this one. So 24-year-old woman is preoccupied with her nose, which she believes is grotesquely large, right? She constantly checks mirrors and has already consulted three plastic surgeons. So she is just concerned about her nose. Similarly, they could this question you about this question in the form of an acne. So the patient is having a very small acne mark, but the patient is thinking that the acne mark is very large and that is causing a lot of problem in the patient's life. Or they could give you a question of that this patient is having that a male person comes to you and is thinks that the size of his biceps is very much small. But in fact the size is very large, and now the patient is thinking about getting steroids. So again, this is a case of body dysmorphic disorder, and in body dysmorphic disorder, we go with SSRIs or CBT as an answer, right? So we completed till all of these disorders. Does anyone has any question? Then we move on to the next topic. Can anyone hear me?
Sorry,
Can
sorry.
everyone hear me clearly?
Yes, we can.
Yeah.
For the trichotillomania, on first aid is written SSRI, so we should cancel that, right?
So what edition of first year do you have?
Oh, I think this is 2024.
No, so I think the latest treatment is CBT. So always stick to CBT. You can cut the SSRIs part out, right?
Okay.
So for
Thank you.
trichotillomania and for body dysmorphic disorder, we go with CBT. Now we'll move on to a very, very important
I
topic
have,
of
doctor, I
yes,
have one question.
yes,
So in case of panic attack, as you said that in case of acute attack, we need to give benzodiazepine. So, but
yes.
so how long we will continue benzodiazepine? So, is there any chance we can move on CBT or SSRI?
Yes, so just to end that panic attack, we'll do a benzo. So if we give a benzo and the panic attack ends in 1 hour, we'll after that we'll stop the benzo. We won't give any more benzos, but then we will refer the patient to a psychiatrist or a psychologist to start the CBT and SSRI as soon as possible as we can. Okay.
Okay, thank you.
So benzos are just to terminate the attack, nothing more, nothing less. Because remember, benzos have a very high chance of being addictive, and they have very high addictive potential. So we do not give benzos in every case for
Oh,
long.
okay, thank you.
Okay, so
Actually,
now we are moving on to yes, yes.
when we should think about in the OCD patient, when we should think about the SSRI, like
So
why we
again,
think about in that patient, why we think about the CBT in the scenario one.
okay. So whenever again, OCD is very similar to all of these trichotillomania and the other thing. So in case of OCD as well, the first line treatment would be CBT. But if symptoms are not getting controlled with CBT, then we would move on to SSRIs. Okay. And again, in CBT, we would give exposure therapy. So what was exposure therapy? So for example, if the patient is having an obsession of contamination, so we would first of all watch him video, show him pictures of people eating food with contamination. Then we would show him videos of people eating food with contamination. Then we would contaminate the food in front of that patient or eat the food in front of the patient. And then we would give the patient antibiotics by himself. So this is the way of gradually increasing the exposure, which is known as the exposure therapy. So first line treatment would always be, yeah, you can think of the CBT, and if that does not control the symptoms, then we would move on with SSRIs. Okay,
Okay, thank you.
okay, okay. So now the next one. So 34-year-old male, army veteran. So this is a disorder called post-traumatic stress. It is most commonly present in patients who are with the army. So this is an army veteran and represents to the clinic with complaints of poor sleep. Okay, so in army males, they would have a history of poor sleep, nightmares, and irritability, right? So they would have a history of mood symptoms, right? And then they would say that they are re-experiencing the same problem. So if I make it easier for you, so imagine that you had an exam and you performed very poorly in the exam, and after that exam for 2 or 3 months straight, whenever you sleep at night, you cannot sleep, you have nightmares, and you say to your mother or to your doctor that when I wake up, I have this flashback of me sitting in the exam and me not knowing anything, and I'm very worried about the exam. So, and I just feel like I am in that situation again, right? And you avoid all of these situations that are related to the exam. So you do not even look at your books. You do not go to the college anymore. You do not go to the exam hall anymore. You do not talk to any person in your college, because whenever you talk to those people, you re-experience your fear of the exam. Then this is PTSD, right? And this should last more than 1 month. Again, the criteria of time are very important, and you should keep them in mind. So PTSD should last more than 1 month. Okay. What's the treatment? Again, the first line treatment would be CBT. And after CBT, then we do SSRIs. And again, we do exposure-based CBT, and we'll do the exact same thing that we are doing. And another thing that they can ask you a lot is, if the patient is having nightmares in the case of PTSD, what do we do then? So if the patient is having nightmares, then we give patient prazosin. So in case of nightmares, we give the patients prazosin. Okay.
Hi, doctor.
Okay.
Can I ask you one thing?
Yes, sure.
Okay, so for PTSD, do you have to experience the past event or stressor yourself, or can you see somebody else experience it and then it causes you PTSD later on?
Can you like elaborate your question a bit more?
Yeah, like for example, like if one of a loved one or somebody is experiencing something like bad happening to them, right, or something life threatening, or if a loved one is diagnosed with cancer or something, but like you're not the one who's having that stressor, but you can still have PTSD from that loved one
Yeah.
having something.
Yes,
Okay.
exactly. Exactly. So,
Okay.
one question, the way they like to test a lot is that since in US, a lot of families like to have their dead one's funeral by the river. So you would have seen in a lot of movies, whenever a patient dies, the funeral is at a river. So whenever someone's loved one die, they go to the funeral at a river. So they would give you a very sneaky and snarly question in which they would say that that a person comes to you, and that patient says that whenever I go to a river or a pond, I cannot sleep at night. I'm having nightmares. I'm having irritability, right? And at that, whenever I go to a river, I experience fear or I experience paresthesias. And then they would ask you, what's the most likely cause of this thing? So if you look closely, the most likely cause was that his brother or his sister or someone very close of his, like uh, his father or his children died, and they had his funeral at that place, and now he's having PTSD whenever he goes to that place, right? Okay. So that was PTSD. So for the nightmares of PTSD, we give a drug which is known as prazosin. So what is prazosin? So prazosin is alpha-1 antagonist. So prazosin is alpha-1 antagonist, and for PTSD, we do prazosin for the treatment, right? And again, if PTSD lasts for less than 1 month, we call it as acute stress disorder. In that case, it would become
Excuse
acute
me, sir.
stress disorder. Yes,
Sir, so according to this question, the answer would be exposure therapy with cognitive behavioral therapy, right?
yes, exactly.
But sir, don't you think that a person who is like suffering from PTSD, giving him exposure of the things that he is having that stress from can worsen his condition?
Okay, so remember one thing. In the case of PTSD or any psychiatric problem, the main problem that the person is having and what is CBT? So basically CBT is the psychiatrist or the psychologist training the human mind or the human brain to recognize what the pattern is going on in that person or what is the pattern that is going on inside of you and how should you treat. Telling you about acute stress
Okay.
disorder. So, acute stress disorder is a condition which is very similar to PTSD, but it lasts for less than 1 month. So, according to researchers, and they ask this question a lot too in USMLEs and in viewers, that what is the most beneficial therapy for acute stress disorder? So, for example, if a patient had his leg amputated due to an army affair or there was an intermittent explosive disorder, which is known as an IADNH, just bursted and this patient had his leg amputated. And then they would argue what would be the next best step to prevent the presence of PTSD in this patient. So the answer would be some kind of an exposure therapy or some kind of insight, talking about that person to get an insight into his brain as to what is going on. Okay. So, for example, let's make it very simple. So, if someone's if someone's father dies or if someone's parents dies or his daughter dies or someone's died, first of all, the thing that you would do is you would give that person some time, 7 to 8 days, and then you would talk that person out of that thing, right? And then you would say that these things are common, these things happen. I'm here with you, and let us look at what caused this condition, what happened in this condition. Because in PTSD, what is happening is that the person's brain is stuck in that moment. So, since the person's brain is stuck in that moment, the person cannot move forward. So, whenever he's sleeping or he's anywhere, and does not have a conscious control over his brain, his subconsciousness will take over his brain and he will experience those things again. So, we need his conscious brain to take over his subconscious brain. And for that, we need to give that patient exposure because in the earlier conditions, the thing that happens was so much rapid. The attack, the explosion of a device, the passing away of someone, that was so rapid, and there were so many problems with those conditions that the patient did not have enough time to cope up with those things. So now the patient needs to mimic this condition again, and in this condition the patient will be trained properly to deal with all of those conditions. And once he gets to relive that experience and relive that experience in a good way, then whenever that experience come against in his mind, he would be able to combat that experience in his mind, and that won't cause any more a problem anymore. Okay.
Okay. Thank you, sir.
Okay. But again, this will be very gradual and it won't be very fast. Okay. Okay. So now we will be moving on to personality disorders. So there are three kinds of, so what are personality disorders? So remember guys, whenever we grow up, we develop some kind of habits. We develop a behavior, we develop a pattern. So normally this pattern is normal. But if this pattern becomes abnormal and it is not normal, then this is known as a personality behavior, right? And there are two things. One is a personality disorder, another one is a personality trait. So I have told you that all of us develops the different personality traits and different set of abilities throughout our lives. So no more of the behaviors and the trait or the patterns that we are having are normal. For example, someone's parents scolds them a lot. So right. So they have developed this behavior that their parents scolded them a lot. So now when they have children, they will scold them a lot too. So this is a normal personality trait. There is nothing wrong with it. Right. So now again, uh, if someone has a personality trait of walking 1 or 2 hours after eating, and this is a behavior which is occurring throughout his life, and he likes this thing. So again, this is a personality trait. Or if someone meets some other person and he smiles whenever he meets some other person. So again, this is a personality trait where he is very right. So contrast between these two, and the US analyst could ask you about a normal personality trait, and they could ask you what kind of a personality disorder is this. And at the end, there would be an answer that this is a normal personality trait. Okay. So there are three kinds of personality disorders. We group the personality disorders into three types. So the number one is cluster A. So the cluster A are very commonly related to schizophrenia. Then there are cluster B. Cluster B are more likely related to dependency. And then there are cluster C disorders. And cluster C disorders are most likely related to anxiety and avoidance and a fear of getting rejected or low self-esteem and low self-worth. Right? So we'll go over these personality disorders one by one. So first of all, let's move on to paranoid personality disorder. So what is paranoid personality disorder? Paranoid personality disorder is very simple. It's just like it's just like every one of us has an uncle in our neighborhood who is very distrustful, who does not trust anyone, and whenever you meet that person, and he will be asking you a lot of questions. So this is the paranoid personality disorder. So the most common thing that they make you do is they make you confuse paranoid personality disorder with delusional disorder. So we covered this delusional disorder yesterday. So what is delusional disorder? So delusional disorder is that you are having a single delusion or multiple delusions about something, right? So I can give you an example. So a 50-year-old male comes to you, and that patient says that the FBI or the FIA is trying to kill me because I am the biggest person in this world. Upon asking further questions, you come to know that this person does not have any such other problems in his life. So, what is the most likely disorder? Diagnose, is it a delusional disorder or is it a paranoid personality disorder? Because in paranoid patients would do the same. They would say that this person is trying to kill me, or this person is following me and he will try to kill me. But the difference in this case would be the paranoid personality, since all the personality disorders mean that the patient is having a lifelong history of that problem. So that thing would be present over the course of multiple years. And that question would mention that over the past 9 or 10 years, that patient has put multiple accusations on different people about stealing. The patient has a fence around his house because he trusts no one. He's very vigilant. He's cynical of the world. He thinks that everyone is trying to get away with his money. So when the question makes you think in this way, then it would be a paranoid personality disorder. But if the question simply give you the person is completely normal, but he thinks that someone is trying to get away with all of his money, then that would be a delusional disorder. Okay, the second one is schizoid personality disorder. So schizoid personality disorder is very simple. It means there is a person who is very aloof. It's not schizophrenia, it's very schizophrenia. Like in this case, only the negative symptoms of schizophrenia would be present. So what are the negative signs? The flat sign, the elogia, the anhedonia. The patient won't meet anyone. There won't be any delusions. There won't be any hallucinations. The patient would have very limited emotional expression. The patient won't care a single thing about uh, what others think of him, right? So he would just stay alone. He's just like that person in your class who likes to sit alone. Uh, uh, he's just like that person in your class who is sitting alone and who wants to sit alone. He wants no one to bother him. Okay, so that would be schizoid personality disorder. And so the third one in cluster A is Okay.
We can't hear you.
So the Okay. So the third one is schizotypical. So what is schizotypical? Schizotypical personality disorder is just like those people that have very odd appearances. So if there is a winter weather, they will wear very short clothes just because they want to look very different from everyone. They will look very different from everyone. They will have very different thoughts about things. They would say that uh, this car is the fastest car in the world, even so it won't be the fastest car in the world, right? So they would have very odd behavior. They would be very odd. Clearly see them that they are being very odd, right? So, for example, if everyone came to a wedding, so they could give you a question that there was a wedding and everyone came to the wedding in a normal way, or let's make it another way. So they could give you a question that a person came to you for routine checkup or a psychiatric evaluation, and when you saw that person, you have seen that that person is wearing a very long robe and a wizard-like hat, right? And the patients say that wizards are the best thing in the world, and wizards can cure any problem. Upon further examination, the patient is not having any delusions, the patient is not having any hallucinations or any disorganized thought. So then we could ask you, what's the diagnosis? So the diagnosis would be schizotypical disorder. Remember, all the cluster A personality disorders, remember, they won't completely fit the criteria of the person. There won't be any psychosis. The intact reality would be intact. But in case of schizophrenia, the reality is not. So in case of schizophrenia, the reality is never intact. In case of disorder, patient would be normal. They would have normal and real functioning of their mind and life. Okay. So that would be cluster A. So now let's move on to cluster B. So the
Yes,
cluster,
can you
yes.
repeat your mic is breaking.
Okay, can you repeat?
Okay. Okay. So that was cluster A. Now
Can you please explain again the typical because I couldn't hear anything about it.
okay, wait a second. Let me change my network first. Can you guys hear me properly now?
Yes.
Yes.
Oh, okay. So I was saying that in case of cluster A personality disorders, all of the cluster A personality disorders mimic schizophrenia, right? So whenever you see a cluster A personality disorder question, there would be an option of schizophrenia as well. There would be option of psychotic disorder as well. There could be option of schizophrenic disorder as well. But in case of cluster A personality disorder, remember this one thing: the reality is intact, right? The patient will know who is the patient. The patient won't have any delusions. There would be no delusions. There won't be any hallucination. There won't be any disorganized behavior as well. No such things would be present in this case. Whereas in case of schizophrenia, the reality would be very much intact. The patient would have delusions. The patient would have hallucinations. Now let's move on to cluster B personality disorders. So
Sorry, Doc.
cluster
So
B comes. Yep.
because your mic was cracking, like, could you repeat schizoid and schizotypal?
Okay. So in case of a triggered personality disorder, the patient wants to stay alone. The patient is very aloof. He does not want to meet anyone. He does not want to talk to anyone. The patient is completely most important thing is the patient is completely being alone. The need anyone himself. That is in case of schizoid disorder, the patient won't need anyone. But in the case of avoidant personality disorder, the patient also won't need to meet anyone. The patient will stay alone. He will be alone in his own house. He will be alone in his class. He will be that kid who will be staying alone in all of that case. But in that case, the patient would want to have relationships or friendships with other people. But why won't he have relationships or friendships with other people? Is that because that patient thinks he has a very his His self-worth, his self-esteem is so low that he thinks that other people think very low of him. He's very embarrassed to have a friendship. That is why they are not. So the we covered.
Your voice
Uh,
is breaking.
Your mic is breaking. We did not hear. Oh my goodness.
okay, wait a second. Wait a second.
Can I repeat that, sir?
We didn't hear your explanation. Your mic was breaking and it like disconnected.
Sir, your voice is breaking. Can I repeat this too?